Hello class, this is Tujang with Clinical Medicine 2 class, ATSU Module 9 video discussion. This is a case about a 71-year-old female with pulmonary metastasis from the sigmoid colon. 5 years prior, she did have sigmoid colon resection for cancer. She recently underwent a CT scan which revealed a mass in the left upper lobe of the lung. She has a history of hypertension and osteoporosis. Current medications include raloxifene, alpha-calcidol, fexofenadine, pseudoephedrine, and esomeprazole. She is a smoker, 2 packs a day for the past 45 years. Physical examination on admission was unremarkable. She underwent ECG, which showed sinus rhythm with an incomplete right bundle branch block. She had placement of an epidural catheter between the 5th and the 6th vertebra. Tracheal intubation was accomplished and general anesthesia was maintained. The left upper lobe lobectomy was successful without difficulty in an operating time of 157 minutes. No arrhythmias or severe hypotension were detected during the surgery. She was then transferred to a general ward after the surgery. The first day post-op, she did fine, no problems, no complications, no arrhythmias or atrial fibrillation. The second day post-op, she was noted to be leaning towards her left side during assistance with urination. She developed a left hemiparesis, right conjugate deviation, and slurred speech. She underwent emergency MRA, and the epidural was immediately removed. An acute cerebral infarction was diagnosed as the cerebral MRA revealed a cessation of blood flow to the right internal carotid artery. She was then transferred to another hospital to receive intravascular therapy. She received 4,000 units of heparin. 4 hours after the onset of arterial occlusion, extensive dark brown thrombi were removed from the intravascular catheter and cerebral perfusion was reestablished. She received protamine at the end of procedure. Anticoagulation therapy was delayed until post-operative day 21 because a minimal hemorrhagic infarction had developed. She recovered with only mild paralysis of the left upper extremity, and she was transferred to a rehabilitation facility on post-op day 37. So the incidence of cerebral infarction after pulmonary lobectomy is reported to just be 0.6%, which is very similar to general surgeries or cardiac surgeries. However, it's reported that the incidence of cerebral infarction, and specifically left upper lobe lobectomy, is as high as 4.5%. In the study noted in my written discussion by Yamamoto et al. 2015 demonstrated that patients with cerebral infarction accounted for 4.2% of all patients who underwent left upper lobectomy, and the proportion of patients who underwent the left upper lobectomy for lung cancer was significantly larger in group of patients with cerebral infarction than their counterparts. Both the studies in this case and the Yamamoto study showed a mechanism of cerebral infarction after the left upper lobe lobectomy to be include stasis of blood flow in the stump of the left upper pulmonary vein due to its longer anatomical length and stasis. So, with left upper lobe lobectomy patients, early post-operative anticoagulation should be indicated to prevent thrombus formation, as the incidence is significantly higher compared to just pulmonary lobectomy and general surgery at 0.6% compared to 4.5%. So if you have any questions or comments, please leave them down below, and I would love to hear them and respond to them. Thanks.